dedicated to treating cancer patients. And on that, I've got to apologize to the meeting because I've been called out for a cancer patient tomorrow, and I'm going to have to leave the meeting early. But having said that, I'm going to give you the talk on one of the areas that I've been doing some pioneering work on, and that is in minimizing the scar in mastopexy, which is breast lift surgery. This is my disclosure. The breast is a symbol of femininity, and no woman wants to have scars on her breasts, whether this be for augmentation, for breast lift, or for reconstructions. They certainly don't want to look like that. Can we dim the lights? Women certainly don't want to look like that, and this is one of the standard forms of breast lift performed today. This is known as the anchor scar. So what do we do when a woman like this comes into our practice and says she wants a breast lift, but she wants no scarring? Well, let's look at what is available. The standard technique, as you saw, is the anchor lift, where an incision is made around the nipple, a vertical scar and a horizontal scar. And this is the resultant type of result that you get with this technique. Recently, a newer technique has been introduced, and that is the vertical breast lift, where an incision is made vertically on the breast and we eliminate the horizontal scar. Interestingly, we are now using the same technique for patients undergoing mastectomy for breast cancer. And here you see the procedure. The vertical scar is made, the skin is removed around the areola and vertically, and the skin is tightened, and that's the sort of result you can get. We're reducing the scars, but there still is a visible scar. The next improvement has been the donut mastopexy, where skin is removed around the areola, and the resultant scar is just a scar around the nipple. And as you see, the skin is excised, and that is the resultant scar. Well, this looks fine, and you hardly see the scar, but what happens with time, that scar tends to stretch, and the breast tends to droop. So it's not the ideal technique, and this can be the worst case scenario, where the scar really stretches out. The reason for this is that sutures alone cannot hold tissue. We know this from a cheese grater. If you place a cheese grater on butter, it will cut right through it. So the same with a suture. A suture to hold a muscle or tissue will cut right through the tissue. This patient came to see me, and she said she had a perfectly good result immediately after surgery. She was very happy. And as the months went by, the scars simply stretched. So a technique that I've developed and actually published is called the subareolar mastopexy. And what we do here is we make an incision around the nipple, and we elevate the dermis and tuck it underneath the areola, which is raised on a pedicle. So this dermis is tucked underneath. We then use multiple sutures to anchor it into position. And this is almost like a tongue-in-groove repair. So there's no tension on the skin. All the tension is taken deep inside, and that helps us. This is just another technique of folding the dermis in under the areola. And this is the actual surgical technique. The skin is removed. Now, normally with the donut mastopexy, the skin is sutured to skin, and that just tends to stretch out. So with this technique, we elevate the areola partially, we make an incision, and this brings us down to the pectoral muscle. We can then manage the glandular tissue in any way we want. We can make a vertical incision and tuck it up to elevate the lower pole, to prevent the lower pole from sagging. And we then close the dermis and place our first purse string suture around the areola. This is a braided nylon suture which gets tissue ingrowth. We then place a second suture, and sometimes even a third, on the dermis. We then let the skin go back, and as you see, there's zero tension on the skin. We actually have an excess of skin. A couple of examples. Here's a patient before surgery with a sagging breast with large areola. Early after surgery, this is just a few days, you notice there's no tension on the skin. And there she is from the side. And a few months later, she is healed, and the scar is barely noticeable. Another patient with large areola, same procedure performed, just a circular incision around the areola, so the breast is lifted and there's no visible scar. A larger breast patient, same technique, scar around the areola, no tension, and this goes on to heal with virtually no visible scar. Now, patients who've already had a breast lift, particularly the old donut type of lift where the areola is stretched, we can go back, revise them using this technique, and months later, they are stable and there's no stretching of the scar. Another revision, this patient had the donut technique. She had her implants poorly placed with a capsular contracture. We revised the whole procedure, revised the scar, revised the implant, and we can get the patient looking good. The implants that we use, this is the standard silicone gel, which is a smooth implant. The implant that I was involved in developing was the adjustable breast implant, which is available in a saline version, a combination gel saline, and the anatomical. Unfortunately, due to the FDA requirements in the US, these are not available in the US. They're available in most other countries around the world. The only one we have available in the US is the saline version of the same implant. This is what the implant looks like. It can be placed underfilled. It can then be expanded, and then the volume reduced and the injection port removed. So we can use this type of implant for breast augmentation, for patients undergoing breast lift that want augmentation as well. And this is my standard implant that I use today for breast reconstruction. When a patient's had a mastectomy, we do the reconstruction through a vertical incision, the same that we use for a breast lift, so that when the patient has had the mastectomy, there's no stigma of a mastectomy. She looks like she's had a breast lift instead of a horizontal scar. We do nipple sparing mastectomy so the patient can look totally normal. We adjust or expand the tissue. We then take out the injection dome once she's reached the right size. So here you see a patient wants a breast lift and an augmentation. We use the adjustable implant here. Saline is injected post-operatively to get the right size, and there's her final result. And there you see the side view with a good lift and virtually visible scarring. Another patient, same technique. Skin is excised around the areola, closed with the subdermal technique, the adjustable implant, and there you see her result. And one more patient with the same technique. See the asymmetry, the lower breast, post-operative adjustability. Another patient with asymmetry. We use the adjustable implant. In this case, we exteriorize the injection port so that she doesn't have to come and have it removed later. And you see we can get perfect symmetry and virtually no scarring. In dark-skinned patients, they're always concerned about keloids. And here you see her result. Even though she wanted a fairly large implant, we can still avoid tension on the areola. And you see a close-up view, the scar is virtually invisible. And a side view. And we can use the same technique in men. Men are particularly concerned about scars on their breasts because men walk around topless all the time. So in a male like this, we use the same technique around the areola. We take out the excess breast tissue, and there you see virtually no scar, and he can wear his bathing trunks to the beach. Another patient with asymmetry. A young girl with asymmetry where one breast is lower than the other. We do an augmentation and get the areola symmetrical. And here you see another patient, front view, before and after, before and after, before and after. And another patient with asymmetry, once again with the implants, before and after. Patient had a previous donut lift with stretching of the areola, and we revise her implants, and we can give her a good result. Now, this is one of the worst cases that I've seen, and she came in and she said she wants this corrected, but does not want any visible scarring. So we had to go redo the scars, replaced the implant. We were able to get her to that situation. Another patient with stretching from the donut mastopexy. You see her result. And this is the patient I showed you in the beginning. A really very bad stretching. We took her back. We didn't cut out any of the areola. We just let it retract back. And that is what it retracted back to. That's how much tension there was on the skin. So in order to reduce the tension, we advanced the dermis underneath and then closed the skin tension-free. And although not perfect result, we were able to get her to that, and she was very happy with that. One of the big advances in breast surgery today has been the advent of mesh. And there are various types of meshes that we have available, because as I said to you, sutures don't hold very well. So we have biologic mesh that either come from human donors or animals, either porcine or bovine. And we have synthetic meshes, which can either be permanent, can be absorbable, or combination. So patient that I showed you in the beginning, when a patient like this comes in and wants a breast lift, there really is no way to do that without using a mesh support. We use mesh as a hammock or an internal bra. We placed that in, and we were able to get her to that, result with virtually no visible scar. The only scar is around the nipple, but the mesh is doing most of the lifting. And now you see her a few months later. Now, a lot of focus with breast lifting has been to push the breast up from the bottom. And we've realized that you can't really push the breast up from the bottom and expect it to stay there, because the minute you take the support away, it's going to just drop right down. So we're now moving more towards elevating the breast from the top up. Sometimes we combine the top elevation and the lower lift. So here you see a patient with droopy breasts. This is the long-term absorbable mesh. We put it in as strips, and we anchor it almost to the clavicle. From the clavicle to the areola, we suture that in, and we use our circular incision once again. But you see the elevation in the upper pole that we get with the mesh. Another patient with very droopy breasts, same thing. You see here she is on the operating table before we put the mesh in, and when we've tightened her with the mesh, we can get excellent elevation of the breast. Another patient, very droopy breasts. We use the combination of the mesh, the superior mesh and the inferior mesh. Another patient with tubular breasts, pointy breasts. We use the same technique. And there you see the mesh being tied in to the upper pole. You see the great amount of elevation you can get on the operating table. And post-operatively, the patient's breast will really elevate it very nicely. Thank you very much. And once again, I do apologize. I'm going to have to leave prematurely, so I may not be able to give all my talks. Thank you.
I take the immense pleasure of inviting Dr. Angelo Ribello to felicitate Hilton Becker with keynote.
Dr. Becker, congratulations for your presentation on behalf of the Omics, the certification of recognition.
Thank you
very much again.
Thank you.
Thank you.